a talk that I like to call a urologist and a sex therapist walk into a bar. And we're going to talk about the role of sex therapy in treating erectile dysfunction. And with us tonight, we have Erika Pluhar. So Dr. Erika Pluhar, she's got her PhD and a bunch of other letters behind her. And
Lots of letters.
She is a psychologist who specializes in sexual therapy. And I recently had the opportunity to sit down with her a while ago, and I'm like, we've got to do a webinar because this is hot stuff. And unfortunately, a lot of patients don't get to sex therapy because they're afraid, because they're embarrassed, and it is so important when we talk about men's and women's health, especially sexual health, that I said we need to do this talk. And so I'm Marc Greenstein. I'm a urologist with Advanced Urology, and Erika is with Whole Heart Psychotherapy. And Erika, you want to just say a couple of things about yourself?
Sure, yeah. I'm actually not a psychologist, believe it or not. I am a licensed marriage and family therapist and licensed professional counselor. And my PhD is, it's okay. My PhD is in human sexuality, and my counseling degree is in counseling. So put the two together, sex therapy, and I'm clinical co-director of Whole Heart Psychotherapy. It's in Buckhead. And along with a strong sex therapy, couple and sex therapy contingent, we have a whole bunch of other mental health offerings. So you name it, we have it pretty much.
Yeah.
And I'm really happy to be here. Thanks for inviting me.
Right,
and I liked your title.
Yeah.
While we walk into a bar. So I came up with a cartoon right off the bat to match that.
Nothing like a little Charlie Brown. It's awesome.
Exactly.
All right, so let's see here. Let's see if I get the slides right. Bear with me. Nope, not that. Nope, not that. That. Okay. So we're going to talk about a couple things tonight. Mostly, we're going to talk about erectile dysfunction, sex therapy. What is sex therapy? How does sex therapy help with erectile dysfunction? And then we're going to talk about a couple of cases and examples of things that we would see in our office and in my office and in Erika's office. And also just a little disclaimer, let's try to hold ourselves to mute while we're doing the talk. That way there's no interruptions. We can slam right through this and you can get to any sports or Netflixes you're planning to do tonight. And then there's a chat box that you can load your questions into. You just kind of have to search around on your Zoom channel and you can find it. So what is erectile dysfunction? Basically, erectile dysfunction is the inability to get or keep an erection sufficient enough for satisfying sexual activity. And so for a man, because it looks like that's what we're going to focus on here, it's basically blood supply going into the sponge of the kidney, the sponge of the penis, and that sponge traps blood within it. It compresses the connective tissue that's part of the penis. The blood stays in, and a guy gets an erections. And you basically need, I'm gonna change this around a little bit. You basically need three things to have sex. One, you need hormones like testosterone. Two, you need blood vessels. And three, you need a nervous system. So the nervous system and the psychological factors kind of are part of the nervous system. And so you need those three things in order to have intercourse. And when I see patients in the office, I can eye them up within a second if they have those three things. Like it takes me like literally a second, because if they're walking in and they look fine, I know that their blood supply and their nervous system is intact. And then it's up to me to find out about the psychological and the hormonal stuff as I get to know that patient.
If I could just add one thing,
Please.
The definition isn't just about sufficient to have any sort of penetration or intercourse. It's whatever a man would consider satisfying sexual activity.
Perfect. Exactly. Thank you. All right. So some statistics, 52% of men have some form of erectile dysfunction. It increases with age, starting at around 40. Nope, that's not okay. And then definitely by 70, there is ED gets increased 5% per year by the age of 40 and up to 15% by 70. I think that's what that statistic means.
That means like complete ED, I think, like across the board.
There you go. Yep.
Yeah.
Age and physical emotional health most strongly correlated with ED and decreased sexual desire. So some men, as they go through life, they're going to notice that their libido is going to go down, their interest in sex goes down. But sometimes we see it in younger people too, when they're just not in a good place, and that's why we have people like Erika here. So some medical physical things that I see in the office, vascular is a big one. So poor blood supply, such as heart disease, such as stroke, those are big things. So in other words, if there's bad blood supply to your heart, like for someone who's had stents put in their heart, or if someone has had mini strokes, I know that the blood supply to the penis is also not so good. Diabetes is a huge one. Unfortunately, we have to blame diabetes for almost everything when something goes wrong in the body, because elevated sugar levels are toxic to the body. That's why we try to keep our sugars around 90 to 100, if, just by our own body regulating insulin and other hormones. And when sugar starts to rise in the body, it literally attacks the cells. And so what cells do they attack? Blood vessels and nerves. And if the blood vessels start to misfunction or misbehave, the blood can't get to cannot get to an organ. If the nerves start to misbehave, then the nerves that are innervating that organ can't do their thing. Medications are a big one: beta blockers, blood pressure medicines, antidepressants, also glucose medicines. Some of the prostate medicines I use will do things to a guy's sexual function. Pelvic surgery and trauma, that's a big one in my world because of all the guys that are getting prostate surgery, such as prostate cancer surgery or radiation therapy or seed implantation. That's a big one. Neurologic, so that also involves strokes and mini strokes, but it also could involve things like multiple sclerosis, people with bad backs, herniated discs, Parkinson's, things like that. Endocrine, also a big one. When I went first into practice almost 20 years ago, I didn't realize how much testosterone mattered in men with erectile dysfunction, but boy, is that a big one. And so when we see guys that are not waking with an erection, the first thing I think of is low testosterone. And then of course, there's the unknown, just things happen. Anything you want to add, Erika?
No, that's great. That's an awesome overview.
So what's some of the treatment that let's move our little picture here. So what are the treatment options? So of course, we have our lovely blue pill, Viagra. And then after that, Cialis was invented. And then after that, Levitra was invented. And then after that, Stendra was invented. And Stendra is something that people don't even know about because they just don't have a good marketing department. But those are the four, we'll call them magic pills. And what they do is they try to just drive blood supply into the penis when a man is trying to get aroused. You can't just take the pill and look at your penis. It doesn't work that way. And so
common misconception.
Yeah, you need to have stimulation, you need to have foreplay, you need to have mood, you need all that stuff. Injection therapy means that we teach you how to use a medication, and you use a tiny little needle, almost like an insulin needle or a tuberculin needle. And men will inject a medicine right into the side of the penis. I'll back up, just like, if you can see my mouse here, but this red area of the penis, the men will learn how to inject the medicine right into that area. And that's magic, because 10, 15 minutes later, they're going to get an erection. So if they go out, down into Buckhead and just stand naked in the park and inject themselves, first, they'll get arrested. Second, they'll just get a boner right in the middle of public. All right. So pumps are vacuum assisted devices or vacuum erection devices. And those are a combination of a restrictive ring, so a ring that goes on the base of the penis, and then a pump that literally acts like a vacuum to pull the blood into the penis. And then the ring, the restrictive ring stays there, pump comes off, and the blood gets trapped into the penis. Now, I'm going to tell you that is not a wonderful thing. We use it a lot in our world to do some form of therapies for men with like curvatures of the penis, men with who are just having prostate cancer surgery and they just need to get more blood supply in there, things like that. Implant surgery, that's what we love to do. Urologists are kind of weird in the head with stuff like that, but we do surgery to put a device in. And once that device heals up and a man wants to have sex, they just pump it up. Or some of them are what we call malleable. They're just these malleable devices. They're down, they're up. They're down, they're up. Those are, in our opinion, urologist's opinion, those are wonderful things because it's sex on demand. You want to have sex, pump it up. You don't want to have sex, put it down. You want to have sex 10 minutes later, have sex 10 minutes later. You don't have to worry about drugs or medicines or vials or anything. Testosterone therapy, like I mentioned, about 20% of guys with low testosterone, about 20% of men with erectile dysfunction have low testosterone. And so we will give men back their testosterone either in a synthetic form, like a gel or an injection. Sometimes there's pellets that we use that we implant under the skin. And then there's a medicine called clomiphene, which is used to help women have babies because it plays with estrogen levels. But by playing with estrogen levels in men, it allows men to get their own testosterone to be made again. So it's the only pill that I know of that allows a man to make his own testosterone again. And I'm a big fan of that stuff. But we do a lot of testosterone replacement in the office. And then pelvic floor physical therapy, that's a huge thing in my world, because a lot of people come to us, men and women, with these muscle and nerve dysfunctions where things are just out of whack. And we need a physical therapist that specializes in this part of the body to kind of reorient things and get the blood flow better, get the nerves better, get the muscles to relax, and they can work magic as well. Erika, anything to add?
No, that was awesome. I did talk to a PT yesterday who was saying that the obliques seem to be really involved, and she was telling me about a case where she did some dry needling on this guy's obliques, and it really was magic for his ED. So I hadn't heard about that connection, but
yeah, the obliques are the side here. Obliques are your sides.
Yeah.
All right, next slide. All right, so Erika, take over. It's all you.
Yeah, so what is sex therapy? It is a specialized form of talk therapy. So contrary to some things we may have seen in movies like Meet the Fockers or Meet the Parents, we don't actually, people don't have sex in our office. There's no nudity, it's just talking. And it's focused on improving sexual functioning and satisfaction. So along with ED, we can help with lots of other issues related to sexual functioning. Low or absent sexual desire is probably the biggest thing that we see. Painful sex, and orgasm issues, of course, ED, history of sexual trauma or abuse, out of control sexual behavior, otherwise known as sexual addiction, and lots of other things. So we usually integrate it with couple and relationship therapy because there's an adage, like if somebody's in a relationship, you're not having sex in a vacuum. Like there's a person involved there and there's dynamics involved there. And so the gold standard is to try to involve the partner. And we give a lot of homework. So at-home exercises.
So that homework is awesome.
Fun stuff. Well, yeah, we'll talk about some homework examples a little bit later.
It's not like telling my 14-year-old, listen, you got to get that math done.
Right. It's definitely not math homework.
All right. Next slide.
So we take a biopsychosocial approach. Sex is really complex for human beings. As Dr. Greenstein was just going over all the possible medical causes for ED, there are psychological and social factors that can contribute as well. And that's what we deal with in sex therapy. So on the psychological side, anxiety and depression can play a role. Stress, of course, can play a role. Having had a history of sexual abuse or trauma may be in the mix. Sexual shame or guilt. This crosses over into the social side, but like people who were raised in very strict religious, sex negative religious households who have a lot of shame and guilt about like sex being bad. Those kind of ideas and beliefs can really impact somebody's ability to like be in their body and experience sexual arousal. Attachment insecurity, that means how you feel in your relationship and how you manage closeness and distance. And so that would be some territory we would get into as well, into couple and sex therapy. On the social side, if somebody's having a lot of conflict and they're always fighting with their partner and they don't know how to resolve that productively, it can decrease the safety in the relationship and the security, and that can impact somebody's willingness to seek out or be receptive to sexual activity. It could also really impact if somebody is having erectile dysfunction or another sexual problem. If there's a lot of conflict and blame around that in the relationship, it can really impede a couple's ability to work that through and find a productive solution. So we would help with that for sure. Communication difficulties. We generally don't grow up learning how to talk about sexuality very openly, like most people don't. We don't really learn how to communicate about our sexual needs. And so those can be awkward discussions for people, and throw in a sexual functioning issue. And there's a lot of pressure and a lot of embarrassment. And so we help people have those conversations a lot more smoothly. And then culture and gender messages. And the big one there is that men are pretty much given the message that they're supposed to be ready for sex at all times, that it's all supposed to work. They're supposed to get an automatic erection and take charge and not have any problems. And so when there is something that's not working, it can really go against that messaging and create a lot of internal conflict and conflict in expectations in a relationship. So we help people in that area as well. This PLISSIT model is something that we talk about in the field of sex therapy. It stands for permission, limited information, specific suggestions, and intensive therapy. A lot of what we do is in that PLISS part. We help people. I mean, where else can you go and talk with a professional really openly about your sex life? And we get into details like, how do you start? What do you do? What happens when, where do things break down? How are you feeling about it? What happens afterwards? We really want to know so that we can be helpful along the way and figure out where the problematic points are. And a lot of that is permission. And then we're doing a lot of education. We're giving specific suggestions. And sometimes we're delving deeper into deeper emotions, childhood stuff. So we do across the board. Next slide.
Excellent. Woo, busy slide.
This is a very busy slide, but I can explain it. So two researchers, Jansen and Bancroft at the Kinsey Institute at Indiana University, put forth what's called the dual control model. And it's based on the idea that in order for sexual arousal to happen, there are two systems that need to be in balance. The sexual excitation system, which is like your turn-ons, and the sexual inhibition system, which is your turn-offs. So if you think about an accelerator and a brake in a car, we need to have the right balance of foot off the brake and foot on the gas in order for arousal to happen. So turn-ons could be how your partner smells, what their appearance is, what sensations you have in your body or don't have in your body. Hearing the sounds of sex, newness, falling in love. And then on the turn-off side, all the things we just talked about: relationship conflict, not feeling good about your body, having a history of trauma, being exhausted, depression. So we will dig in and help people figure out, like, okay, what do we need to do to take their foot off the brake and remove some of those factors or minimize them? And what do we need to do to put the foot on the gas to help arousal happen?
So
Go to the next one. Oh, go ahead.
so what's the stuff in the corner, like the little black box here, the process of becoming?
The process of becoming aroused is the process of turning on the ons and off the offs.
Oh, I see. Okay.
Yeah. So it's just more of the same, explaining that concept.
Okay.
Where this is useful is that I think a lot of times people are like, well, I'm just not turned on enough. And of course, if there's medical, physical things going on that override that, they need to be addressed. But we also have to address a lot of the negatives that are getting in the way. And so we do that in sex therapy. We will dig into all of those things and help people rework them and learn different ways of relating to themselves and their partners that don't trigger a lot of those negative factors. So this slide shows the feedback loop that can happen with ED. So if we have a loss of erection or an erection that's not, a man can't get an erection, that's a negative experience. Then the next time around, he starts to anticipate that will happen again. And there's that anticipatory anxiety, which is often worse than the actual event itself. So then there's a focus on performance and what's going to happen. And in sex therapy, we call that spectatoring. It's like you're up in the bleachers watching what's going on instead of in your body, being like present in your sensations. And when that's happening, stress is increasing. So turn offs, foot on the brake, and arousal is decreasing, turn ons. And loses the erection, negative experience goes around and around again. So we like to get in there and see where can we interrupt this cycle. And instead of it being so performance and goal oriented, how can we help a man just tune back into his bodily sensations and like what is available to him? So that mindfulness piece really comes into play there.
Big word, mindfulness.
Mindfulness, yeah, we can define that for folks. Mindfulness is being present with what is happening in the moment. So when it comes to sexuality, it's a lot about sensation, temperature, texture, pressure. Instead of what's usually happening in this feedback loop is, oh my gosh, am I going to lose it? Is he or she going to be disappointed in me? Am I going to fail again? What's wrong with me? And all of those thoughts really spike anxiety, which causes distraction from the actual stuff happening in the body. So we have to train our brains to like come back to the present, come back to the body. And we have lots of different ways that we would help people do that.
Yeah, it's meditation.
It's basically meditation. Yeah. One of the concepts that we use to combat this performance mentality is, and I'm a stickler on language. I like to be really intentional about the language I use when I'm working with my patients. Like even the word achieve orgasm. If we don't achieve, what's the opposite of that? We're failing. And so we can experience orgasm or we can experience arousal. It just is it's a subtle difference, but I think it really matters because so many people are taught that sex it's a goal. It's a goal you're going to get to. You have to have the erection and then you have the orgasm. And in a heterosexual model, it's penis and vagina intercourse, mutual simultaneous orgasm. And if you don't do that, you fail. Well, that is just not sustainable for any people across the lifespan with anything that could happen related to body changes, illness, having babies, etc. So we work with folks to help them normalize what we call good enough sex. And that if you take this normal curve here, the majority of sex that a couple has could be good enough. It's like, it's not super awesome, fantastic, like the movies or porn sets it out to be. That's up here in the small standard deviation, upper standard deviation of this curve. But the most of it is good enough. Down here in the second to last segment, we've got good for one and okay for the other. And then the bottom of the barrel is like those just sucky experiences where we want to help people keep calm and laugh it off. So But that's unfortunately where so much of that performance cycle comes from. It starts with one experience that didn't go very well or didn't happen as you expected it to happen. And then it plants those seeds for the next time. I'm anticipating it's going to happen again. And it should be these fireworks, but it's not. And so pressure, 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 instead of thinking about, okay, most of it's supposed to be good enough. Doesn't have to be perfect, but good enough. So we help people reframe their thinking about sex. Okay, we talked about homework. So this is another, this is a big sex therapy tool that we use. Masters and Johnson were the mother and father of modern day sex therapy. Some of you may have seen the show on, I think it was Hulu, Masters of Sex, about their lives and work. But they developed this set of exercises, touching exercises for couples. And it's basically about mindfulness. It's the idea is to take the pressure off performance and outcome and just be present with what the sensations are in your body when you're giving and receiving touch. So we would give this as an assignment to a couple to go home. They can do it with clothes off or with some clothes on. I like to make it very customized to wherever a couple's comfort level is. We want to set them up to succeed with this, so to speak, although that's kind of performance-y too. But we would say go home and set aside about 40 minutes to give and receive touch. And at the first level of this, breasts and genitals, if it's a heterosexual couple, are off limits. So you're just touching other areas of the body and giving feedback about what feels good or what it feels like and how it could feel different in terms of better sensual experience. You're not supposed to go on to have any sort of genital sex. You're not supposed to go on to have orgasms. It's just what it is for that experience. And that's really different for a lot of couples, especially couples who are trapped in that performance feedback loop. To have somebody say, okay, take that off the table, just go and do this, kind of back to the basics. And it's not even about getting aroused. It's just about experiencing your body. And the other thing that people get to practice is the ebb and flow of sensation and arousal, which is really normal. A lot of guys and women think that you're supposed to get and maintain an erection the entire sexual experience. And that's just not accurate. It ebbs and flows. And so we want to help people get used to that idea so that they can think, okay, that's normal. And the panic response doesn't start to come in like, oh, I'm failing, here we go again. And then Sensate focus progresses to include breasts and or genitals the next time, but not go on to intercourse or orgasm. And then eventually a couple can reincorporate that. But sometimes taking a break from penetrative sex can be a huge relief for couples that are having erectile difficulties and other sexual problems. You just take a break, take a vacation from that, focus on other things, and kind of get back to that foundation of touching. Here's the other thing about this is that at the beginning of a lot of relationships, most relationships, this kind of touch happens naturally all the time. And over time in relationships, people touch less and less, and they take less time to have sex. We save it for the end of the day when we're exhausted and the kids go to bed, and that's all we have left. We're running on fumes and we expected all the work. And it's just not fair to our sexual response when you don't have the newness and the novelty of a new relationship. So this is a great way to return to that non-demand touch, non-demand pleasure. Do the next slide.
Yep. Hold on, I got someone popping in there. So this can also be good. This idea can also be great for someone who has a wife who is also having problems on her end.
Yeah, absolutely.
It's not all just about him. So,
that's right.
Yeah.
Yep. And whoever the person is in a couple who's having the problem, that's a lot of pressure on that person. We call it the identified patient. And they often have feelings about being broken, about being blamed, and maybe their partner is blaming them, like, you need to go fix this. So this really equalizes the playing field and gets back to, let's just figure out how you like to be touched by one another.
Yeah.
Also, people who are having ED or other sexual difficulties, it gets to be so frustrating sometimes in the relationship because the sexual experiences aren't working. It's not uncommon for them to come to us sex therapists and not even be touching at all. So there's just no affection, because if we even hold hands or kiss, that could lead to the feeling of failure again. So we often have to get couples back on track with just basic affection.
I love homework.
Home play. Well, that's a good transition to this. This is a handout that I will give couples who, so say we've got a situation where they're not touching much at all because this has just been so problematic and frustrating and they're so stuck. So I really want to find out what kind of touch is available to them. And it may not be a whole lot at this point, but we got to start somewhere. So I break it up into 3 types of touch: affection, non-demand touch. And non-demand touch is like not just sensate focus, but all the stuff, again, that people did a lot at the beginning of relationships. They take showers together, they snuggle naked and spoon in bed, they cuddle up on the couch, tangle up their feet. Like, all of that it's not touch that's going to any goal per se, but it's really connecting. And it helps lay the groundwork for transitioning to genital or erotic touch. So that's the 3rd category. So I would give this to them and I would say, fill this out and let's see what's available to you now. And we may not go down and do non-demand touch or genital touch. We might need to just start with affection and rebuild that. And we're rebuilding emotions like trust and safety and the bond in the relationship, so that they can take risks with one another again and go into these scarier areas where they've been so stuck.
Nice. Next. All right, case examples.
Cases.
All right. Let's see. How do I do? Oh, there we go.
I think I put these on fly in, so per click.
Okay. How's
so great. So here we've got a 45-year-old male, and he is coming to you, Dr. Greenstein, with high levels of anxiety about sex. He's having a lot of arguments with his partner about his intermittent ED. And you give him a PDE5 inhibitor. Say you give him Cialis.
Right. So the questions I would ask this guy is, 1, are you waking with erections? Because that's a big question for me. And then I would just say, like, what's happening? Is it, can't get it at all? You losing it? Are you ejaculating too quickly? Whatever the story is. And then a lot of times I'll just give them a medicine like Viagra, Cialis, just to kind of get them back in the saddle. And some guys just need that. They think it's just the magic pill. It's going to calm them down. It's going to give them the confidence. But they'll be coming back saying, this isn't working. Do you have a divorce attorney? And it's like, I mean, that's what some guys will say to me.
Yeah.
So, okay. Hormones are normal. You're waking with erections. I can run up your bill because I'm good at that. I have a diploma that allows me to run up a bill. Or I would say, okay, it's time for therapy. Yeah.
Yeah. And I think, if somebody came to me and hadn't seen you first, I would certainly send them to you to screen out all the medical, physical stuff, and probably to start them on a PDE5 inhibitor just to see what happens. Like, does that alleviate enough of the performance anxiety, just knowing that, okay, everything's working and there's something I can do about it. And very likely that's not the only factor. So not uncommon for me to hear situations like, I have Viagra, but I'm not telling my partner about it. Or I got it from my doctor and my partner's pissed because, he or she doesn't think that they're good enough for me anymore, or I'm not attracted to them. And so all this meaning can be developed and tangled up in the medicine even, then that becomes a symptom. So that's, we would help them use the medication and integrate it into their sexual repertoire. And you're doing the education piece too, of like, you pop this pill and have an automatic erection, but sometimes people don't know that. And so they need some coaching around how to actually like facilitate the arousal, when to take it, how to talk to their partner about it. People who are really in arguments about sex, where one person is the initiator and one person saying no a lot, get pretty resentful. Like, I took this pill and then we still didn't have sex. And so we have to help people deal with that.
Yeah. And then the other thing is they'll try the pill and then it works the next day.
Oh, yeah.
There's a lot of that.
Yeah.
Yeah.
Yep. That's where back to that permission, limited information, like the education piece is huge.
Yeah.
And we can spend a lot more time with people too. Our sessions are at least 50 minutes, and we do a really thorough assessment with folks at the beginning to like look at what all the factors are. So whereas you get 10 or 15 minutes at most with people, we get a lot more time to dig in.
Yeah, it depends on what's going on, but yeah.
Sure. We would give him or them tools for, and again, this is a situation where I really want to see the partner along with the male patient. So we'd give them tools for managing his anxiety, like mindfulness, relaxation. Cognitive restructuring is, I kind of talked about it earlier. It's a big fancy psychological term, but it means if the way you're thinking is not serving you, we're going to have to think about this differently. So we're going to reframe things. We're going to, that whole performance mentality, that's good enough sex is a form of cognitive restructuring. So I want to help him adjust his expectations, him or them, to away from that, it's got to be perfect every time, and failure mentality. I would assist the couple in talking about their feelings in an open and supportive way. Harder than you would think when the stakes are as high as they are in marriages where sex is a problem. Because if you think about it, this is the way I describe it. Like, can you get more vulnerable? Sex is like vulnerability on crack. Can you get more vulnerable than you're naked? You've signed on for life with somebody. All your finances are wrapped up together. You've created human beings together if you have children. Families are integrated. And all of a sudden now, like, this is all supposed to work and naked. You're putting your body part in somebody else's body part. That's a lot of vulnerability. And so people develop defenses and avoidances, and they need help breaking that down and talking to one another in open ways so that they can reconnect and problem solve. We say in therapy, in couples therapy, that a couple that's locked in like a defensive pattern, they can't even make a peanut butter sandwich. How are they going to solve a sexual problem? So we want to help open that up. And then again, relearning a non-performance-based script.
How often does it become a Jerry Springer show in your office?
Occasionally it does become that.
Yeah, okay.
Yeah, I've had my share of yelling for sure.
Okay.
So here we've got a 65-year-old male. He is treated for prostate cancer with a radical prostatectomy. And at post-surgery follow-up, he's reporting a lot of distress about erectile function, and he's having some relationship concerns. So yeah, go ahead.
Well, so so these guys are going to be in our office because, you know, we're getting them through their surgery and stuff like that. And so what we do very commonly with these men is we're going to put them on some type of medicine like Cialis or Viagra around the clock. And the good news is that those medicines are generic now. They're very inexpensive, like literally dimes a pill. And the idea is just to get blood flow going into the penis. We have them take the medicine at night because that's when their hormones are surging. When their hormones are surging, it's driving blood supply to the penis, and we want healthy oxygen in there. It's almost like a physical therapy. Some men will also give them the vacuum device. Get the blood supply in there, get blood flow going. And it's really the idea, if you don't use it, you lose it. Now, for men who are really upset and they're like, I need to get back in the saddle fast, I'll start them on injection therapy right away. And that way that they can at least start getting sexually active and at least trying to have, penetrative intercourse. And so that they can try to, get back on the saddle, as I like to say. But sometimes, it's still, you still got to treat this. And so.
Yeah. And of course, there's going to be a lot of emotions for the male patient. And if he has a partner, for his partner, about cancer. I mean, that's a big, scary life health crisis to go through. And not uncommon for it to be really difficult for people to talk about that in an open way and to cry about that or grieve what's lost and what they're afraid of. And so we would help them have those emotions and share them with one another and hopefully lean into one another, because people do develop avoidant patterns. Like, wouldn't it be uncommon to hear of a case where cancer is just so scary, and what he potentially lost in terms of his erectile function and what that means to him in terms of his masculinity, he just shuts down and won't talk about it. And so then the partner is over here going like, what happened to you? I'm trying to connect with you. We've made it through the medical part, like, for at least most of it. What's happened to us emotionally? So we would help bring them back together. Lots of support and education about implementing the things that you recommended. So using the vacuum erection device, using the medication, like making sure there's compliance there so that all that blood flow is returning and he can be, working that through as much as possible. And then we would go back to that touch menu and help them start wherever they needed to start to rebuild and relearn touch, basic affection, sensual, sexual. When there's been trauma, whether it's medical or some other type of trauma, that can get stored in the body. Like, emotions can get stored in the body. And so it might be really scary to return to sexual intimacy because all that area has had a lot of stuff happening to it. So we would help people slowly reintegrate touch.
Is it like a post-traumatic stress disorder?
It could be.
Is there anything different than this than getting in a massive car accident or getting shot or any traumatic event in a person's life?
Yeah, any traumatic event in somebody's life. Cancer, the news of cancer can come as a similar kind of shock, and it's life-threatening. And so
I had that with the patient today. I gave him bad news today because that's my job. And he's a mess. It's gonna be hard to take care of this guy because I think he's gonna dig a hole.
Yeah. I have a prostate cancer survivor now, bile duct cancer survivor patient, and he couldn't even use the word cancer. He called it the C word for months because it was so traumatic.
Yeah.
All right, here we've got a 60-year-old male, and he's reporting early ejaculation, otherwise known as rapid ejaculation, previously known as premature ejaculation. We like all of our language evolution here.
Yeah.
During a new relationship. And so you start him on tramadol.
Yeah, so this is a very common thing. And usually these are guys that have had their entire lives. But now he's in a new relationship and it's like, whoa, maybe I should do something about it. And so it is very common to have this. And, it's definitely some kind of neurologic phenomenon where men get super excited and they have their emission just way too quickly. And it's a miscommunication between the parasympathetic and sympathetic part of the nervous system. That it's the fight or flight. And so, in Europe, the pain medicine tramadol is very commonly used for early ejaculation because it's a medicine that is used to regulate hormones in the brain, such as serotonin. And by doing that, you're taking that person down a level in anxiety a little bit. And so that way they can last a little bit longer. And so we have men who use this just prior to intercourse. Now, the problem with America is that this is a pain medicine. And so I write it for men and then they get flagged by the pharmacy because they ordered a pain medicine. And it's just just terrible that we had to label guys this way, but it works. It works. There are other things out there like low dose antidepressants like Zoloft and Paxil, but those you now have to take on a daily basis. There are some of my partners will use it just before, but I'm not kind of on that boat. I kind of don't like that. But tramadol tends to work well for a lot of my guys. So I use it, but there's definitely a component where they need you. Holy cow, do they need you?
Yeah, and since we're talking about ED, where ED would come in here is if the guy is ejaculating rapidly and then not able to get an erection after that again, the experience would be one of ED. I can't get or maintain an erection for satisfying sexual activity.
Right.
So lots of anxiety. And of course, the anxiety, then we've got that same performance cycle, anticipating, is it going to happen? And then he's even more charged up than he would be at baseline neurologically. And so we would use a lot of the same interventions. We'd help integrate the medication into the repertoire. This is a new relationship, so he may not want to drag his new partner into sex therapy right away. But we would be giving him a lot of tools to help communicate with the partner about what's going on, because he probably has shame and embarrassment and needs to have some coaching on like normalizing this and letting the partner know this is going on, because it helps so much to have partner involvement and support in order to make some changes here. Again, we may not bring this new partner in, but if we did, of course, we do some of the same things with non-performance-based script and all of that.
Excellent. Hold on, got one more. There we go.
So here we've got a 53-year-old male, and he is reporting difficulty maintaining an erection during intercourse. He wakes up with an erection a few times per week. He saw you, and you prescribed him Cialis or tadalafil prior to intercourse, and his testosterone is normal at 650.
Yeah, so this is a very common guy in our practice. We can even flip the numbers and say that this is a 35-year-old male. And in the fact that they're younger, so 53 is a young guy, 35 is even younger guy. We see them in their 20s as well. And it's the same thing. Like I see them walk into a room, so I know the blood supply is working. I know the nerves are working. If I examine them, I have to look at their genitalia, because if they come in with little itty bitty testicles, something's up. But if they come in with normal sized testicles, I'm going to assume that their testosterone is normal. A lot of guys, because of commercials and magazines and who knows what they're seeing out there, they want their testosterone level. So this guy, it was normal at 650. Anything less than 350 is considered low. We usually have to draw blood work twice in order to prove it. But this guy in particular is normal. And then this is the type of guy that he's fine. He is fine, but he's having issues. And so, I would give him the tadalafil to get him back in the saddle, and then hand him over. Yeah.
And same stuff. So if this is a longer term relationship, we would want to get the partner in. We would want to talk about how they're using the medication, what that means to both of them. Are there any barriers, anything that's getting in the way to using the medication? We would help him identify the thoughts that are contributing to his performance anxiety and replace them. That's that cognitive restructuring I talked about, with more accepting or neutral thoughts. Same thing with the partner. We would help them communicate more openly and help them develop strategies to focus less on outcome and more on the process.
Excellent. Excellent.
That's it.
Yeah, I think we did it. Let's see.
We did it.
So everyone, you got some phone numbers here for Erika.
Our website lists. Our website lists all of our providers. We have 6 providers, 7, including me, who are couple and sex therapy specialists. And a lot of people have room right now, and which is uncommon for therapists. So we're happy to accommodate some new referrals. And people can call that general number or reach out to our scheduling email as well, and we'll help match people with providers.
So I want to thank Erika for help put this together. This is, I think this is a great thing that we can do for people. It's unfortunately still just not an open conversation. You know, you're not like playing golf with your buddies and you're like, so how did your appointment with Erika go? You know, unfortunately, it's not that. I can completely understand if nobody wants to ask any questions here, but you know, certainly you're welcome to. You know, we're kind of an open book. We've kind of seen it all and heard it all. There's kind of nothing that shocks us when it comes to stuff. This is a very important part in a men's health world and female health world, because as urologists, we do both, and Erika does both as well. And I think it's a very important topic, specifically for me, who's managing men's health, you know, with their testosterone, their sex life, their urinary care. It's all tied in because it's all involving the same structures.
Yeah. Yeah, and that's such a good point about there are very few forums where people can talk openly about their sexual health, and it's such it's your birthright. It's such an important part of being a human being, and oftentimes relating with another human being very closely. So
yeah,
I'm so glad that you suggested this and that we could put that out there.
So if people don't know me, I tend to kind of joke around a lot. It's just the way I handle myself. But you know, when guys come to me and they talk about, you know, a lot of times I'll be like, haven't you seen The Blue Planet? Haven't you seen the shows on BBC where the walking Jerry bird is going around making the nest, and it's all about eating and having sex. That's what it's all about. And I kind of look at the same thing. I'm like, where are we eating?
Yeah. And
anyway. All right, looks like we do have a question here. And so for post-prostatectomy, how do you typically prescribe medicines daily? So what I do is I prescribe tadalafil, which is Cialis, 5 milligrams at bedtime. You use a GoodRx card. So a GoodRx is like a prescription plan that's out there it's basically like a Costco of prescriptions, but you can pick and choose your pharmacy that you want to use. So you go to like Costco or Kroger, and by using the app or the card, it gives you a discount to the drugs. So anyway, I prescribe 5 milligrams at bedtime. You just have to watch out for a headache and a little bit of sinus congestion. If that's starting to work and men are starting to get some erections, but they just need a little bit more oomph, they can take an extra one every once in a while. But you can't take more than that because of blood pressure and headaches. One of my partners, he does things a little different. He will prescribe Cialis or tadalafil 20 milligrams, which is the kind of the highest dose, and he'll have men take it Monday, Wednesday, Friday. And I guess the idea is he's just giving bigger peaks of the drug as opposed to what I'm doing, which is more of a steady state. So that's what I tend to do. Now, if someone is starting to get erections, so let's say they've had a prostatectomy, 6 months later, they're starting to get a little bit of erection in the morning, you know, with foreplay, they're starting to get a little bit of an erection. Then I'll just say, well, maybe just try full dose Viagra or Cialis. And you know, you take it 30 minutes, an hour beforehand, and hopefully it goes well. So I hope that answered this man's questions.
Great. Any other questions?
Anything else, ladies and gentlemen? Well, we're gonna, this is gonna eventually go on the Advanced Urology YouTube channel. We have a YouTube channel, and it'll take a little bit, you know, a bunch of business days to get it done, but the web channel is bit.ly/urology-YT. All right, and so it's going to go on there, and I cannot thank Erika enough for helping us have this little chat, and I hope everybody learned something.
Thank you for inviting me. It was great.
This was awesome. All right, Erika, have a good night. Good night, everybody.
Take care. Good night.